you can tell. For those of you that don't know, we have the Parkinson's Activity Center in Green Valley. We are open Monday, Tuesday, Friday from 1 to 3:30. And your Parkinson's support group has activities going on 6 days a week. One of the things that we get asked all the time is, how can I replicate this back where I come from? Because we have nothing like it back home. And the key to me is every one of you who help provide the activities, to bring your passion, to bring your ideas, and those of you that donate, because we survive on donations and grants. So I just want to welcome you, and I'm going to read Dr. Reed's little bio here. Dr. Reed is one of the few movement disorder neurologists in our Tucson, Green Valley area. She specializes in the diagnosis and treatment of neurodegenerative disorders that affect voluntary movement. She is particularly interested in improving the quality of life for patients with Parkinson's disease. She stays current in her approach to the diagnosis and treatment of movement disorders by being an active member of the International Parkinson's and Movement Disorder Society. She earned her medical degree from the University of Arizona College of Medicine. She completed her residency in neurology at Barrow Neurological Institute, Phoenix, and then stayed on at the Muhammad Ali Parkinson Center and Movement Disorder Clinic to complete a 2-year clinical fellowship in clinical movement disorders and deep brain stimulation. She was first board certified in neurology by the American Board of Psychiatry and Neurology in 2008, and again board certified by the National Board of Physicians and Surgeons starting in 2018. So I would like you to please give a big round of applause to Dr. Reed.
I had run out to the car. I was overheating. I had to put my headband on. Do I have to do anything to turn this microphone on, or is it good? Good. Okay. That was an awful lot of stuff to say about one person. And actually, I'm just like everybody else. You know what I dreamt about last night? I dreamt that, just choked on my saliva. I dreamt that I was back in high school, and my girlfriend that also we both played flute and band, and she didn't want me there. And I was wanting to get into marching band, and I wasn't smart enough to do the marching. I wasn't physically good enough. I wasn't smart enough. And at different times in our lives, how many of us get times like that where we just feel like I'm not good enough? And yet that's absolutely not true. Thanks. All of us, in whatever state we're in, we are good enough. We are worthwhile, and we are good enough. So just keep that in mind. You're important to somebody. Might be somebody you realize you're important to. Might be somebody you don't realize you're important to, but you are important. So, okay, I think I can just go this way. We don't really need to talk about objectives. First, we're going to just talk about what is Parkinson's disease. Can't even see the slide here. Okay. Got enough space? This is poor vision and old age, you know? I can see the shapes of the words, but I can't read them. So anyway, Parkinson's disease, there are 1 million people in the United States right now with Parkinson's. Can you believe that? 60,000 people every year being diagnosed. And worldwide, there's 10,000 people with Parkinson's. So it's a huge problem, and kudos to people like Muhammad Ali, Michael J. Fox, Davis Finney, Michael Grant, all these people, Gant, I think, not Grant, but anyway, all these people that have brought it to the forefront to really place an emphasis on it. Basically what it is, it's a degenerative disease, a neurodegenerative disease. The first most common neurodegenerative disease is Alzheimer's. Parkinson's is the second most common. Most people are diagnosed over the age of 60. A lot of my patients are even over 70 or 80 at time of diagnosis, but they can be as young as 50 or lower. We call that young onset Parkinson's if it's less than 50. But there's even people that are down in their 20s and 30s. So I'm glad that would be a very difficult thing to deal with. Some of the early symptoms of Parkinson's, to just do the halfway, yeah, okay, so probably can't read this. These are some non-specific symptoms. Let me read them to you. Constipation, loss of smell, dizziness or fainting, trouble sleeping and mood changes. Who's going to think of Parkinson's when that's all they have? Not me. So these are non-specific things, and they can start 10, 20 years before you actually get the motor symptoms to where somebody can say, aha, I know what this is. Even when the motor symptoms start, they're gradual in onset. So it leads to difficulty in diagnosis sometimes. And some of you are probably pretty frustrated that it took a couple years to get diagnosed. Some of these other symptoms are small handwriting, soft voice, loss of expression of your face, stooping posture, trouble moving or walking, and tremors. So those are a little bit more easy to identify. And tremors, a big thing about tremors, you might have gone to a doctor that said, I don't see the pill rolling tremor, like where your finger and thumb are moving together. I don't see that, so you don't have Parkinson's. Well, you know what? 80% of people have tremors, but 20% don't have any tremors. So you can't rule out Parkinson's that way. Also, of those people that have tremors, not everybody shows it the same way. Everybody's got unique symptoms. As far as what causes Parkinson's, age is the biggest risk factor, but even then, it's only a risk. It's not an absolute. If we all lived old enough, like maybe, 120, then we might all get Parkinson's. But over our lives, from the time we're born, we accrue damage to a certain part of our brain that is made up, one part is made up of dopamine cells, and those dopamine cells are part of an autopilot circuit that runs our movements in our brain. By every day we age, we get exposed to things externally, pesticides, herbicides. We get exposed to inflammation in our body, whether it's from our diet or from illnesses we have. And we may get traumatic events, get hit on the head by a softball and get knocked unconscious, or fall out of a tree as a kid and get knocked out. Those are all risk factors. And over the years, each of these risk factors does a little bit of damage to the cells, a little bit more damage, a little bit more damage. And when you've damaged a certain threshold, that's when somebody gets the symptoms, because their autopilot circuit isn't properly running anymore. It starts to fail. Genetics is something that, it's in the news. You hear about genetics of Parkinson's. But one thing to know is that only about 15% of people have a gene for Parkinson's disease. And again, just having the gene does not mean you're gonna get Parkinson's. That's another couple of ticks on your accumulation of damage over the years. If you think of softball or baseball, you get 3 strikes and you're out. Parkinson's, let's call it, 1,000 strikes. So if you get the genes, maybe for Parkinson's, maybe it's your first 50 strikes, but you still gotta add to it and get enough damage to actually have the disease itself. This is, afterwards, if you wanna have a copy of this set of slides, you can, and that's partly why this is here. It explains what I just talked about with the loss of dopamine over time. Let me see if there's anything I missed. No, we talked about that. Okay, so the last one, medication. When we've accrued enough damage and that circuit doesn't work anymore, because it's dopamine cells that are dying off that are the problem, we can actually give medication to help the brain replace that dopamine. There's dopamine in some of the foods we eat, but it's too big of a molecule to get into the brain. There's something called the blood-brain barrier that protects the brain from bad things getting in. And so that prevents big molecules like dopamine from getting in. But somebody, in their wisdom, in the 60s, figured out that when the body makes dopamine, the last ingredient that it uses before it turns into dopamine is called levodopa. And levodopa is small enough it can get into the brain. And so that's what we do. Since about 1967, we use dopamine in the form of levodopa, a precursor to dopamine, a pre-ingredient. And that can get into the brain and help those dopamine cells push out more dopamine. One aspect of this that affects how you respond to medications over the years is that when you're born, you have about 400, 500,000 dopamine cells. You got this many. And by the time that you're diagnosed, you've lost about 3/4 of those, so you only got this many. If we give you a little bit of dopamine that first year, that's good enough. We kind of call it a honeymoon phase. You can miss a dose, you can be late with a dose. Most of what you're getting is from those cells that are still producing dopamine in your brains. So that's good enough, and that's why I call it the honeymoon phase. But from that year to 5 years later, to 10 years later, to 15 years later, what your brain makes keeps declining. So we have to keep adjusting the dose up to make the difference to have enough dopamine to run your circuit. And so two things that contribute to that. One is that those dopamine cells are dying off, and so they're not producing as much, but also they can store up the levodopa. So early on, you can store up the pills, and it'll last longer than what the pharmacodynamic curves in chemistry say, how long it says it should last. You know what I mean? So it actually lasts longer than you'd expect. But as the years go by, that's where the rubber meets the road. You have fewer cells making dopamine, and you have less storage capacity. And that's where you start having complications, call them wearing off. A dose kind of runs out before your next dose is due. And when that happens, you might get your tremors back, you might get your shuffling back, or your stiffness, or your slowness. And it's just a matter of how many dopamine cells are left in your brain. And so we deal with that by adjusting how you're doing your medications. We might adjust the dose up, we might adjust it more often. So a couple of key things to know about your Parkinson's disease. Basically, everybody with Parkinson's has stiffness and slowness. That's two of the things we use to diagnose it. Not everybody has tremors. Not everybody has gait difficulties, at least not at the beginning. And then beyond those four, those are the diagnostic symptoms, but beyond those, there's a good 50, 60 different symptoms. I mean, you get just overwhelmed if you looked at the whole list. But a key thing to remember is it's a syndrome. Each person has their set of these few symptoms. And so when you come into a support group like this, or when you go into an exercise class and you see somebody else that's very different than you, don't expect that's going to be me, because everybody has a different set of symptoms and they have a different progression. And so just keep that in mind always, because otherwise it can be pretty depressing. As far as sightedness, the Parkinson's tends to be lopsided. Most people, it's lopsided. It starts in an arm or a leg, eventually goes to the rest of that side, or it goes to the other side. And the fact that your dominant hand or your non-dominant hand is affected is totally up to chance. That's just an interesting factoid about it. So here's the top four symptoms are the symptoms they use for diagnosis: the rigidity, the slowness, the resting tremor, and then postural instability goes with the balance. Postural instability is something that's pretty unique to Parkinson's. Balance is very multifactorial. If your vision's poor, your balance is going to be worse. If you've had vertigo in your inner ears, your balance is going to be worse. If you've had back injuries or neuropathy with the nerves in your feet, those are all things that can affect how the nervous system works together to keep our balance good. But this postural instability is something in particular where you might be standing there talking to someone and kind of start going backwards and not even realize it. And it might be hard to catch your balance, like take a step and catch your balance. So sometimes doctors will check that in the office by pulling on your shoulders to see where you're at on that. The tendency is to want to fall backwards, but it could be any direction. And one thing is, if you're having falling very early in the diagnosis, say within the first year, then it'd be really prudent to go to a neurologist right away, get things figured out, and start working on balance. The secondary symptoms are kind of things like mentioned in that prior slide with, actually the first one, freezing. I want to talk more on that. Freezing is something, another way to put it is a motor block, meaning that autopilot circuit just kind of stops, gets locked up. Most often, freezing happens with walking. And there's certain situations that tend to break it on. One of them is if you're in a particularly closed area and you're trying to turn around. It gets hard to get your feet going. So it's like they're glued to the floor, or your feet feel like, a million pounds are just stuck to the floor. So that's why I call it freezing. You're frozen to the floor. It can also happen if you've been sitting a long time. When you first get up after this talk, you've been sitting for however long, and you try and start walking, that can be a time where that circuit doesn't want to kick in right away. As soon as it kicks in, it gets easier to walk. But that initial start gets hard. Turning, starting, doorways, something like doorways, anything that visually closes in on you can cause freezing. And the way to get around it, I think of freezing as like little roadblocks or potholes in our brain. And when we first learn to walk as a toddler, all we do is the absolute basic starting out walking. We don't do any skipping, jumping, stepping over things at first. We are just one foot in front of the other. So I think of that as the most hardwired in our brain. That's the most likely movement to get stuck. So if we add in a different movement into that, we can kind of incorporate other neurons that aren't stuck and get the movement going. For instance, pretend like there's something laying on the floor in front of you and you have to step over it. That's a more complex movement that takes more neurons. Another way might be marching in place, or just thinking numbers, 1, 2, 3, 4. Music is something that incorporates both sides of our brain and really gets the brain activated and can help when somebody gets stuck. An interesting thing about freezing, though, it's not just the feet. The speech can get frozen too. Whole body movements can get frozen where you momentarily get stuck. So that's another thing to be aware of. When the disease is earlier on and you first start having freezing, it might just take some adjustments of your medication, and then you can get rid of it again for a while. Some adjustments of the medication, some physical therapy, adjusting how you think about it when it happens, but then we can get rid of it again for a while. But once somebody's had Parkinson's for long enough, it gets hard to get rid of the freezing, even if the medication's perfect. Let's see, so stooping posture, handwriting getting smaller, facial expressions, saliva and drooling, those are all other things that can affect people. A comment about the last couple, the lack of facial expression and drooling. Drooling is because our autopilot isn't reminding us to swallow our spit. And so every so often, the spit builds up enough and it overflows. How many people like to do that in front of other people? Not me. Nobody does, right? You don't want to be seen doing that. And with the lack of facial expression, it makes it hard for other people to read what you're thinking. They might think you're mad all the time, and it's just that you've got a flat face where there's no, inside your head, you think you're doing the expressive things, but on the outside, it's not seen. All those muscles are stiff and slow also. And then the voice being quiet. All those things contribute to people wanting to go out and socialize. And actually, socialization is a great thing to help keep our brains working well. It is by far superior than sitting absorbing a TV show. But when people with Parkinson's get some of those symptoms, they start to isolate. They don't want to go out to a support group like this, to exercise classes, to luncheons with people. And so being aware of it from both sides of the issue can help us deal with it, help other people that have that, encourage them to come out. And for the people that have it, realize that other people understand. The other people with Parkinson's, some of them may have your same issues. There's a whole lot of non-motor symptoms. Motor symptoms are movement symptoms. Non-motor symptoms are everything else under the sun: sleep, thinking, mood, can even be pain, blood pressures, having your blood pressure drop and where you pass out. And then even things like the psychosis, hallucinations or things. All those things can happen at different times. Some of them tend to happen earlier, like constipation tends to happen 20 years, 10 years before the diagnosis. Others, like cognitive decline and hallucinations, tend to happen later in the diagnosis, but still not everybody gets them. If you look at people that have had Parkinson's if you look at people that have had it 15 to 20 years, only about 40% would have enough cognitive decline where they need help with things, and that qualifies you for dementia. If you're no longer independent, you need help with things. So still, that's not everybody. The diagnosis of Parkinson's has traditionally been by going into an office, sitting in front of a doctor, and hopefully it's not the case where they watch you walking in the door, you sit down and they say, "You got Parkinson's, goodbye." Hopefully that's not the case. But it could be as easy as that, because now that people in here have Parkinson's, they know people with Parkinson's, you can see how if you know what you're looking for, you can see it. Other people might not think anything of your symptoms, but if you're looking for it, you can see it. So an exam, a neurological exam, and looking for or listening for what people say have been happening is the mainstay of diagnosis. However, especially at the beginning of symptoms, when you just have a few of them, but not very many yet, it's a gray time where somebody might say, "No, absolutely not," or "Absolutely, yes, you do," and they can be wrong. So one big thing about diagnosis is just following over time. If something over time doesn't sit well with you or your doctors, it needs to be taken a look at again. Some things that can help with diagnosis, one of them is called a DAT scan. It's a scan that uses a contrast that actually lights up part of the autopilot circuit. If you get an MRI or a CAT scan, that's just ruling out other things. It should be complete. An MRI and a CAT scan should be completely normal in Parkinson's. They would only show if you've got something else, like a stroke or a tumor or something. So MRI is just optional if you think there might be something else going on. Levodopa, the medication, is something that can also help diagnosis. However, the downside is that sometimes doctors say, "Here's the pills, come back in a couple weeks. Do you feel better?" Well, what does that mean? So that's not very helpful either. It's more helpful if the doctor is actually especially a neurologist, if not even a movement disorder neurologist, so that they know what to look for and help you to know, is the medication truly benefiting your symptoms, not just making you feel better, and who knows what that means. There's a skin biopsy that's been out for maybe a year now or so. The company is based in Phoenix, actually, and they take a little punch biopsy. If you know what a punch biopsy is, it's just a little circular punch, and they would get one here, one behind the knee, and one behind the ankle. And there's dopamine in different parts of our body, not just the brain. There's dopamine in the retinas, there's dopamine in the skin, in the gut. And so they're using the skin and staining it for the dopamine, and they can have a good idea, not just whether or not you have Parkinson's, but it can actually help differentiate one of the atypical kinds of Parkinson's from the usual Parkinson's. Atypical Parkinson's is you have some of the symptoms, but it tends to progress faster. It tends not to respond to medication. And so if people are having trouble with medicines or they don't feel like their diagnosis is right, that might be something that could be helpful to say, hey, is it this one type of atypical Parkinsonism? And unfortunately, the only way to get an absolute diagnosis is still once it no longer matters, which is autopsy. So there's a whole bunch of people around that can help you in your journey, help you and your care partners in your journey. Friends, neurologists, primary cares, physical therapy, occupational therapy, speech therapy, all kinds of people, pharmacy, dietitians, all these people. But you are the most important person in your care team. It's often helpful to have, I call it a medical buddy, where when you go to appointments, it's good to have somebody else listening, taking notes, thinking of questions, because when you're in the hot seat, it's often, you kind of get foggy brain, you're like, oh, wow. So it's helpful to have a medical buddy to help you with that. And as far as support groups like this, there's a lot of benefits of being in a support group or an exercise group or anything similar. It's easier to think of the reasons why you wouldn't want to go. For instance, I see people that are worse off than me and it's depressing. What about that? Or they're all so negative. They talk about all the bad stuff. I don't want to go. So it's true there are groups that can be like that, but one big thing to remember, for instance, in an exercise group, if you're the most able person in that group and everybody else is worse than you are, you're doing what you need to do to prevent progression, to like where they are. And another thing is, a lot of times, other people that you're looking at might have something else going on. They might have Parkinson's and an old stroke, and an old back surgery, and an old injury. And so that can also be a reason why they are different from you. But some positive things about a support group. One is the emotional support you get. When you're around other people that have the same issues you have, that have to deal with it, that helps you to feel like you're not alone. And it helps reduce your isolation and depression and anxiety. So it's very helpful. If you go to a good support group like this, you're going to get a lot of education. You're going to learn about different treatment options. You're going to learn about different therapies available, different tricks to do, and that's going to help you to choose the best course of action for you. They say if you know somebody with Parkinson's, you know one person with Parkinson's, meaning everybody's different. It's the same thing with your treatments, whether it's pills or therapies. If anybody else has the same exact regimen that you've got, one year probably isn't ideal for, optimized for yourself, because everybody should have their own unique regimen. Support groups like this are also good for advocacy, including things like getting caregiver support. Then there's practical assistance. I don't know in this group in particular, but sometimes you can find transportation, meals from other people in the support group, learn about home care, or have people in the group that help provide home care. So support groups are very good to be involved with. Finding the right doctor is important as well. Like I mentioned earlier, you'd get the best care from a movement disorder neurologist, but even a neurologist is far better than just your primary doctor. The main thing though, no matter what level doctor you have, if you have a doctor that listens to you, answers your questions, that's the ideal. Because even if they don't know something, they're going to find out for you. So, the different things that a doctor can focus on, one is reducing the symptoms right now, one is preventing complications in the future, and one is improving quality of life throughout the whole course. Another question people have is, when do I start medications? Have any of you been diagnosed less than a year? Everybody's over a year. Okay, good. So chances are likely all of you have been started. In general, the thinking is, if you already have enough symptoms to get diagnosed, it's already affecting your quality of life, and so it's good to go ahead and start. If you delay treatment too long, what I see is people start losing function in different ways. And the Parkinson brain can be affected in a way it's not as able to self-assess. How am I doing? So you might be developing more and more of some kind of a difficulty in function and not realize it. So it's helpful to listen to care partners when they say, hey, you need to do this. So it's not just for starting medications, that's also for when do I increase my dose? When do I add more? When do I do more? There's not a perfect day. If you don't increase today, that's it, you're done. No, that's not true. But there's a window of time, and at the end of that window is when you've got enough symptoms that it's affecting your quality of life, and other people can see that, and maybe you'd be able to, or maybe you won't. So trust in those around you. There we go. Okay, 1967-ish, same year I came out, my favorite joke. Your options of medications were pretty sparse. Amantadine is an old flu medication that was out, not specific to Parkinson's. It was just, one of the first medications used, and it's still used now. But levodopa, the carbidopa-levodopa, is the first medication that came out specific to Parkinson's. And since then, we have a bunch of new options. So this is another reason it's helpful to have at least a neurologist, because they're going to be more familiar with all these different options, all these different tools in our tool chest. Some of these are better for some people than others. Like certain categories are better for people with no cognitive impairment, no trouble thinking or trouble with memory or planning or organizing. Other ones are okay for anybody, any age. Some of them are better for tremor, some are worse for tremor, some have more side effects, some have fewer side effects. So that's where going to somebody that knows the various medications is helpful. We already talked about how your regimen needs to be unique, how different options for different aged people. Another thing, insurance. There's about 4 or 5 big patient assistance programs out there that if you're needing copay assistance, you can contact one of the people in the group and they can contact me, or you can contact me directly. But there's about 4 or 5 big funds that they were a lot better about having monies a year to 3-4 years ago. It's been a little bit more sparse recently with the lack of inflation, lack of changes in the economy, but that's an option. Some of the companies, the drug companies, will have assistance also. So basically the goal of medications is to reduce your symptoms, allow you to function as normally as you can for as long as you can. It's all about maintaining quality of life and with as few side effects as possible. As far as medication dosing, there's all kinds of different people. There's those people that get upset if they're 1 minute late with their pills. There's those that don't care if they miss it by 5 hours, right? Early on, in that honeymoon period, it really doesn't matter. It's good to start training yourself to be more consistent, but it doesn't matter. You can miss a dose. You won't really notice any changes. But as the years go by and your own dopamine in your brain decreases, you're relying on those pills more and more, that's when it's important to take each dose on time, consistently, rather than something like, oh, I don't feel like I need it, I'm gonna wait. And taking it on an empty stomach gets you the best absorption. But for those with nausea, it's better to take a little food with it, like carbohydrates. So another big thing about finding the right provider is that they know what the rules are, but they know when to break them, you know? Some other things to help with treatment. We talked about therapies earlier, physical, speech, occupational therapy. There's the Big and Loud program, which are specifically geared at Parkinson's disease. If you think of pillows or mattresses, good, better, best, that's better. And then even best are things like knockout boxing, rock steady boxing, the Parkinson Wellness Recovery Gym, the Power Gym in Phoenix, not Phoenix, Tucson, because those are top-notch programs specifically geared at what the Parkinson's is causing, how your Parkinson's is affecting your brain to malfunction. Things like Tai Chi, dance, and yoga they've shown benefit in Parkinson's for different reasons. In general, oh, I didn't put it there. I'll say it now. I'll just go to the slide now. There it is. In general, for exercise, there's different types, 4 big types. Cardio, which cardio gets your heart rate up, gets you breathing fast. That's good for even preventing cognitive decline. Gets good oxygen to the brain, good blood supply to the brain. And it increases your endurance. Strengthening exercises is anything like resistance, whether it's lifting weights or just stretching bands. So resistance helps keep your muscles strong. We don't want anybody to lose all their muscle mass and become frail, because frail people are more likely to break bones when they fall. They're more likely to not bounce back after COVID or something else. The strengthening not only improves muscle strength, it also improves bone strength, especially for women with a tendency towards osteoporosis, which is weakening of the bones. A third type of exercise is balance. So various exercises are specifically geared at maintaining your balance. And then the fourth thing is this a blonde moment or a senior moment? It's probably flexibility, stretching. There we go. So stretching, keeping our range of motion. You know, we accrue injuries over time where you can't move as far, and the Parkinson's itself makes all your muscles rigid and stiff, and it's hard to move, so flexibility is important. All of those types are good to do each week, and a good goal is 30 minutes of moderate to vigorous exercise 5 days a week. That's a good goal, but if you're not anywhere close to that, don't try and jump in full force right off the get-go. Start low, go slow, work your way up, otherwise something's going to get hurt, like pulling a muscle, injuring a joint. It also helps to slow progression. If you've ever heard Becky Farley talk from the Power Gym, she could tell you umpteen ways how exercise can slow the progression and how it allows your brain to readapt and learn new pathways and whatever. And so it just works. I can't tell you all the details, she can tell you. What else? Oh, it can also ease secondary symptoms. You know, for constipation, that's like a top symptom. If you don't have it, feel blessed. But most people with Parkinson's have that. And one of the simplest things to do is drink water. The second thing to do is move. As we move, we help push things along in our gut. And both of those things can be free, definitely. Well, they both can cost, actually, but they can be free. So now let me go back to the one I missed. Surgeries and procedures. There are a couple of different ways to treat Parkinson's besides pills or therapies. One of them is brain surgery, and it's similar to a pacemaker for the heart. There's a battery in the chest, but instead of the wires going to the heart and telling the heart how to function, one wire goes under the skin to each side of the brain, and it tells the brain how to function. It works on that autopilot circuit, and it works with medications. Generally, it's not to replace medicines, it works with medicines. And that gives you, especially when you've gotten to the point where your Parkinson's symptoms are fluctuating, your response to medication is fluctuating, it helps stabilize good function all day. There is a newer form of that where they don't have to even make an incision. And it's using MRI-guided ultrasound. So the same ultrasound they use to check a baby or look at your heart, they can use that ultrasound, and it focuses from all different directions into a certain spot deep in the brain and makes a little lesion there. So when you use the battery, that is giving little pulses of electricity to that area and altering the nerve circuits. This other one just puts a permanent lesion in there and again alters the circuits to make up for the problem from the Parkinson's. So it improves symptoms. And it can be done in a day, taking a couple hours, and by that afternoon you can go home. Right now it's FDA approved for tremors, not for the stiffness and slowness. DBS can do both kinds of people. They can do tremor people and they can do Parkinson people specifically for stiffness and slowness. The ultrasound can't do the second category yet, but they're working on it. They've done studies and they're working on getting approval to where it can be. So you could get one side done now, 6 to 9 months later, get the other side done, and that tremendously improves symptoms. There are some symptoms that don't ever respond to the DBS or the ultrasound treatment because they're symptoms that tend not to respond to the levodopa in the first place. Things like balance is so multifactorial. Remember, it takes the eyes, the inner ears, the spine, the spinal cord, the nerves in the feet. It takes all those things working together to have good balance. So that's not something that levodopa can be a quick fix for, nor can those procedures. But there are a lot of symptoms that it can help control. So that's a good new thing that's come out. We also have different types of ways to take your dopamine. If you're taking 3, 4, or 5 doses a day and you feel like all you do is line up your pill bottles and take one after the other like that's your meal, then there's options that are pumps. Partly they're good for, you don't have to keep taking your oral pills, but it's also good because when you get those fluctuations as years go by, it takes the best response you get from levodopa and it spreads it throughout the day. So somebody could hook up their pump in the morning, have good steady function all day and not have to look at the clock to remember doses. At night they unhook and they're good to go. There's one pump out. There's 2 more dopamine pumps that were supposed to be out last year. Now they're supposed to be out this year. And there's also a different medication, more similar to pramipexole or ropinirole, similar to that kind of medication. It's a fake dopamine that kind of acts like dopamine, but it's not truly dopamine. So there's a pump of that that's supposed to come out too. So a lot of new things coming out. Again, these treatments aren't a cure yet, but there are a couple of medications that are being studied that if you read the news reports, they cured Parkinson's in animals. So now they're doing human trials, and there's more than one. There's a couple of them. And they're trying, those dopamine cells in our brain, as they accrue their strikes all through our lives, there's a protein inside that's normally there, but it gets damaged and it misfolds. When it's misfolded, now the brain can't deal with it anymore, and so it accumulates and clogs up the cell, kind of like in a hoarder's house. So the cell can't work anymore and eventually dies off, and you get closer to having Parkinson's. The medications that are in studies now are trying to clean up those cells that are left, clear out that protein that's been misfolded, and get things working better again. So there's I don't know when it's going to come out. I keep thinking, every day I keep thinking, okay, wow, that's new, that's great. It's got to be within 5 years. And then the next thing comes out. Now it's really got to be within 5 years. But all you can do is just keep looking and watching and hoping and participating. So, a couple other things, just nutrition-wise. General common sense for nutrition is best. Most people are deficient in vitamin D, most Parkinson people. So oftentimes movement disorder doctors don't even test it. They might just say, take a supplement for it. For the constipation aspects, good to have fruits, vegetables, fiber, plenty of water. And then for the protein, there are people with Parkinson's that are so afraid of protein, they don't get enough in their diet, and we're partly made of protein. We need protein. But the best thing you can do, so the whole thing, let me back up a little bit. There's an interaction between the protein that we eat if a levodopa pill is in our gut at the same time. The way it interacts is there's a transporter that takes the protein or the pill from inside our gut into our bloodstream so that it can go up to the brain. And that transporter, if you think of it like a little train car, a little coal car, it can only hold so much protein or dopamine at one time, and it transports it to the blood, and then it comes back. So it's got a limit in how much it can carry and how fast it can go. So if you just ate that 72-ounce steak in Texas and you take it at the same time as your pill, there's the high likelihood you're not going to get much of that pill absorbed before it goes out the other end. So online, you might see things that say, you got Parkinson's? Don't eat protein. Nope, not true. You still need protein. It's just you'll get a better absorption of any particular dose if you take it as separated from protein as you can. A common sense thing might be if you take the pill on an empty stomach 30 minutes before your meal, that gives you a good 30 minutes to get that pill kind of getting it into your system. And if you eat first, there's a lot of food there, so maybe wait an hour to kind of let that clear before you eat your pill or take your pill. And that can help with absorption. Okay. Just general living well things. Go ahead and talk about your fears, because guess what? They lose their stronghold when you talk about them. If you keep them hidden or locked up, then they become bigger and bigger and bigger. Stay as independent as possible. On a day when you're in a hurry, you got a doctor's appointment, you're late, go ahead and let somebody help you with your buttons or help you when you're freezing or whatever. But on a day that you've got time, use that day to work on, okay, I'm going to think about swinging my arms, heel first, big steps, things like that. The hardest thing is probably learning to accept help, though. We're all adults. We've gone through life wanting to take care of others, especially younger ones, especially if you have kids. And when life changes and now you're the one needing help, it can be hard. But realize how much it's blessing that other person to help you. Reprioritize, adjust expectations. Maybe in the past you could do 5 things every day and you can multitask, do this and that. But with the Parkinson's, it ends up, because it's affecting your autopilot, you're taking some of your conscious effort to control things like swing the arms, step big. And so it's harder to multitask. Multitasking makes you more prone to falling. And so just be aware, maybe I can't do as much as I used to. If you get too fatigued, fatigue is a huge Parkinson's symptom. If you get fatigued after doing 5 big things in a day, realize, okay, I got to schedule it out. I'm only going to do 2 things every day at the max, or 1 thing, or every other day. Learn how to manage stress, find solutions, think outside the box. Focus on small victories. That's kind of something that Davis Finney would say. You know, the big V, the victory. Whether a person is retiring from a job, irrespective of Parkinson's, or whether they're at the time in their life when they're getting a new diagnosis that's going to change the rest of their life. Those are two major times in our lives when things are going to change. And I don't know about you, but I don't really like change that much. But those are times where, for instance, ending a job. Okay, I'm no longer the doctor. I am now something different. We all have to learn how to invent ourselves, reinvent ourselves actually, and find out, okay, this used to be my sense of who I am. Now I have to find something new. I have to find new things that fulfill me, new things that make me feel important and feel wanted. And it could be anything. It could be taking on a new hobby. It could be going and volunteering someplace. So times like retirement, but especially times like having a disease like Parkinson's, and even along the way, you know, maybe you do fine the first 5 to 10 years, and then it starts hitting the fan. Now it's time to step back and say, okay, what can I expect out of myself? What can I, how can I find things to do that replenish me, that fill my cup back up? Another thing is allow extra time for everything. Goes right along with that. Make a plan, set little goals. When we complete goals, some of the things I put on my check-off list, the days I use a check-off list, even if it's a tiny thing, if I can scratch it off, I feel so good. And yet if I don't use the list, things don't get done. So anyway, and then the last thing is just stay connected and socialize. So I think that's, last thing is just research. I'll just let you know, actually, gray moment, S, Sherman. Dr. Sherman at the university has been doing research all along the years. So he often talks about that on his talks. And now there's a relatively new, like probably a year now, neurosurgeon, Dr. Larson. And he's a neurosurgeon that came from California, very good. One of his big things is doing deep brain stimulation, but he also has done already and is interested in again doing research for Parkinson's. So I don't know what all it could be. It could be like putting growth factors or different things in the brain, things to try and help slow the Parkinson's or help the Parkinson's somehow. So there's even things that will be going on around Tucson that are research related. If you're not into doing something like that actually gets you, changes you somehow, a new drug or a new therapy, there's also just longitudinal studies where they follow people with symptoms to see kind of how do people progress, So, all right, I think that's everything. We don't need the summary. So, are there questions? Okay, front row here. Can I take this out?
You mentioned at the introduction that there are 1 million candidates and 10 million in the world. Mm-hmm. If you just compare those two numbers, our numbers are so significantly greater than the rest of the world. Hundreds of times greater. Why? Good question. So the question is, if you look at 1 million people in the US versus 10 million worldwide, the ratio here is much, much greater. And why is that? And it probably has a lot to do with all those new inventions this last century, these new things we're exposed to. We've got all kinds of chemicals and different things in our environment that actually have good sides, but they have bad sides. I don't think we know all the reasons for that, but I think that contributes. Initially, there was the baby boomer population when they were less than 50. Most of them hadn't been diagnosed yet, but that was a huge part of the population that when they got to their 50s and 60s, then they were ripe of age to get diagnosed with Parkinson's. But it seems to be more than that. And so I think it has to do with all the advances in our culture. So, but yeah. Yes, back in the back. Can I talk to you a little more after we're finished here? The time is first, and has to do with the doctor.
Okay, sure. There's just a personal question. Okay, there.
Can you talk about apathy?
Yes. So apathy and Parkinson's. Apathy is similar to, but different from depression. They look the same to other people, and yet the person inside, there's a different feeling inside. For instance, people with depression might actually feel sad, down, depressed, helpless, hopeless, things like that. Whereas the apathetic person doesn't feel sad or down, they just don't have any initiative to do anything. The outward expression of both of those can be less likely to initiate and go out and do things, less likely to socialize, less likely to do hobbies they used to enjoy. And medication, like treatment-wise, there's medications for the depression, but the medications, like the antidepressants, are sometimes used for apathy, but they might make it worse. They might help, they might make it worse, or they might not work at all. So there's a difference in dealing with apathy. In general, some Parkinson patients can have a big trouble with what we call frontal lobe problems, where they don't have the initiative to go out and do things. Being guided, they can go right along with you and do things, but to step out and start things is hard. Something like making decisions is harder. If you, for instance, something like, what would you like for dinner tonight? Where would you like to go today? Those are open-ended questions, and it's like to pick an answer out of the blue, I don't know. But if you kind of switch it around and do something like, would you rather go to the store with me, or would you rather go to the dog park with me? Those are questions that it's either A or B, and it still gets them out to do something, because generally when people have the apathy, or they don't want to go out and do things, once they get out, they actually enjoy it and they get benefit from it. But it's just getting them across that threshold. So that can be helpful. Other question? You had one here in front.
Could you talk about the difference that you can see between Parkinson's and Parkinsonism? And can you go from Parkinsonism to Parkinson?
Good question. Two-part question. What are the differences that you can see between Parkinson's disease and Parkinsonism, and can you go from one to the other? So Parkinsonism is an overall generalized term that includes Parkinson's disease, but it includes other similar things. Kind of like I call every single facial tissue a Kleenex, but it's not a Kleenex. With the typical Parkinson's disease, the one part in the brain is damaged and it responds to dopamine. It goes in a progression that we expect. There's a certain set of symptoms to choose from for each person. That's kind of all set in that sense. The Parkinsonism can either refer to it's early on and you have some features, but I'm not sure which road you're going down yet. So meaning a general Parkinsonism, I don't know what it is, but it's in that family. Or it can be referring to the split off. If people don't have typical Parkinson's, they have atypical Parkinson's, which also can be called Parkinsonism. Those not only have the dopamine part of the brain broken, something else downstream is broken too, so they tend not to respond to the dopamine, or it takes high levels of dopamine to get a response. And the progression tends to be faster. Those are people that are more likely to have a shortened lifespan than people with typical Parkinson's. We have some red flags that we can look for to say, hey, I don't think you're in the normal pathway. I think you're over there. And they can be falling a lot within the very first year of diagnosis. It could be like dementia, diagnosed even before any of the Parkinson-looking motor features start. It can be autonomic things like passing out really early, within the first year. That's something that doesn't normally happen in the first year of diagnosis for typical Parkinson's. So if a person, even, put it this way, even if a person goes to a movement disorder doctor and on first look, they don't see any of those red flags, and they're assuming we're going down the typical Parkinson pathway, you still, every year, you got to take a look at it again and say, are there any warnings I missed that actually put it in the other category? If somebody does switch from typical to atypical, it's not that the process in their body changed, it's that the person realized, hey, this was a misdiagnosis, and it actually fits better in this other category. So, make sense? Okay. Other questions? Yeah, in the back. Long-term use of it? And what's the question? Just how to talk about long-term use? What are they doing to improve levodopa? When levodopa first came out, it was all by itself, just levodopa, made people really sick. A lot of it got chewed up in the body, so they ended up putting carbidopa with it. That's why you've got that big mouthful of a name of a medication, carbidopa, levodopa. Carbidopa just blocks the receptors here from chewing it up so that more of it gets to your brain without making you sick. The immediate release was the first kind that came out, but it doesn't last very long in your system. If you look at the pharmacodynamic curve, an hour after you take a dose, it's, by 30 to 90 minutes, half an hour to hour and a half, it's already peaked and it's dropping. And by 2 hours, maybe 50%, 3 hours, 30%, so it falls off really fast. And that's why people have to take multiple doses. So the next thing they did, they came up with extended release tablets. Minutely better, not a heck of a lot better, but a little bit longer lasting. They added another ingredient to it that blocks the body's enzyme from breaking it up before it gets to the brain, so more of your medicine gets to your brain. That lasted even a little bit better, but still, people were having to take them multiple times a day. The most recent oral pill that already is on the market is capsules that have little beads in them. Some of the beads are immediate release levodopa, some are delayed, and some are extended release, so it's Rytari capsules. The people that make Rytari have a second generation product that should be coming out this year. It was supposed to come out last year. A lot of things were supposed to come out last year, but it seemed like not much got done. So that's supposed to be coming out. And then the big kind of, for now, holy grail is being able to give the dopamine in a liquid or a gel, just continuous release throughout the day, so that you don't have to worry about ups and downs. When you talk about how many years you've been exposed to levodopa, that has changes too. So early on, you get a different response than later on, partly because you got more of your own cells left to store it up, and partly because the gut isn't as slowed down. The longer you have Parkinson's, the slower the gut can get because the Parkinson's affects the speed. And as the gut slows down, sometimes people take a dose of levodopa and it doesn't do anything. It's sitting in their stomach, but it doesn't absorb in their stomach. That little coal car is down in the small intestine. And so you might take a second dose, no effect. Third dose, finally something triggers it and it moves down to where it's absorbed, and then you go from 0 to 60 and you may or may not have dyskinesia. Dyskinesia is a side effect of being on levodopa for numerous years. Not everybody gets it, but it certainly is more likely in young onset because they're going to have the disease. Like Michael J. Fox has already had it 30-something years, okay? So people that are younger are more likely to get it, and people that are on either more dopamine than they need or just kind of flippantly taking it when they feel like it, so it's inconsistent. Those seem to be things that bring on the response of the brain where it gets overstimulated from the dopamine, and so you actually get extra movements that you don't want. So levodopa isn't something that should be avoided because of that possible complication. It's just something that should be used appropriately. Other things. Anything else about that question? No? Okay. Other questions? Yeah, over here.
Why do some people not respond to carbidopa levodopa?
The question is, why do some people not respond to carbidopa levodopa? There can be several reasons. When somebody's first diagnosed, if it went under the radar for a while, maybe that person's brain already needs, a typical starting dose is 3 pills a day. 1 in the morning, 1 in the middle, 1 in the evening. And it might be that that person already needs 6 pills a day because they actually were delayed in their diagnosis for a while. So if your brain only gets about 80% or less of the dopamine it needs, it just might not be enough to get a response. So it might just be that you need a higher dose. In some cases, it might be that there's a side effect of levodopa that prevented you from tolerating enough to get enough of a dose. Side effects like nausea, sleepiness, whatever. Sometimes it's one of those people with the atypical Parkinsons, where not only is the dopamine part of the brain broken, there's something else also broken, so the dopamine isn't the only thing that's needed to fix it, and so you may or may not see a response. In one of the kinds of atypical Parkinsonism, you can get a response, but you actually want to push the dose to like 10 pills a day before you say it's a failure.
I was taking 16.
And didn't feel any response? So part of it could be one of those reasons I mentioned. Part of it could be also what is the person judging for benefit versus what is the doctor looking at for benefit. For instance, tremors are harder to get control of with medication than stiffness or slowness. And so if somebody's measuring their tremor, they might still have tremor, and yet their hand movements and their foot taps and all that are so much better. So it's an individual thing. It might just be that Parkinson's was never your diagnosis, and that would be a good time to go get, anything like that says, this doesn't fit, it doesn't make sense. She's saying it should be like this, but it hasn't been. Those are times to go back and look at the diagnosis again with some of those things, like the movement disorder specialist, MRI, DAT scan, any of those things, or even skin biopsy. So, in the front.
Can you take too much carbidopa?
The question is, can you take too much levodopa? And yes, you can. In general, you want to take what you need to control your symptoms, but you don't want to advance it so much beyond that dose will be good for the next 10 years. You want to increase little by little as things go on. If somebody takes more dopamine than they need, they're more likely to get dyskinesia, which is little fidgety movements, wiggling movements. Could just be something small like a shoulder elevating. Could be the whole body moving such that they fall out of their chair. The more if somebody already has dyskinesia, the more dopamine you take, the worse the dyskinesia will get. If dyskinesia is too bad, it can affect balance. When you're trying to walk and you get these jerky movements, that can induce falling. It can also cause people to lose so much weight that they become frail, like they can't keep their weight up. So those would be some reasons why you would not want to let dyskinesia go. Besides, once it starts, it's just going to do more and more. There is a second way, though, that I've seen people with Parkinson's that, for instance, I've seen somebody that their self-identity was in their physical abilities, okay? That's who they were. They could do things. And with Parkinson's, it makes it hard to do things, hard to walk, hard to whatever. And you got tremors. So they tended to be on rather high doses of dopamine, kind of self-medicating, trying to get their function as perfect as possible. And their brain took it for a while until one year the brain said too much. And the difference between Parkinson's and psychosis is like a spectrum of dopamine. If you have too little dopamine, you get more stiff and slow and Parkinsonian. If you have too much dopamine, you can actually induce hallucinations, delusions, which are false beliefs like paranoia, persecution beliefs. And so that's what happened. I think in the case I'm thinking about, it was started by something like a UTI that set her over the edge, but 2 weeks of in the hospital for psychosis, having to cut back the medicines, start antipsychotics, do things to manage it. And once that happens, it's like you're more likely to have it happen again, especially if you go back to super high doses. So in most cases, as long as you're using it in moderation, that's not going to, having a full-blown 2 weeks of psychosis isn't what we're expecting. But if we overdo it, that could happen. To me, it seems like it's more either people that really identify with their physical abilities or younger people. Some of the younger people really just want to hide everything because they're in their prime. They're trying to do everything. Are there other questions? Yeah, in the back.
Is anger and paranoia part of the Parkinson's?
So the question is, are anger and paranoia part of the Parkinson's? Mood issues can be a part of the Parkinson's itself. Could be depression, anxiety. If somebody is 15 years or more in their diagnosis, that's when cognitive decline tends to be more common. And the anger and psychosis tends to happen with the people that are going into dementia. So like the 2 times to get psychosis are either when you've been on super high doses of dopamine for way too long and doctors have tried to get you cut down and you just won't, or somebody that's already getting into the dementia category. Those people can have behavioral changes like, well, there's a name of sundowning. Have you heard of sundowning? During the day, like first thing in the morning, somebody wakes up, they're refreshed, they act normal. By 5 o'clock, they're getting tired, they start getting belligerent, angry, they turn into a Dr. Jekyll, Mr. Hyde thing, and it's hard to deal with. And so those are things that are generally related to onset of dementia, onset of the progression of the cognitive decline. And along with cognitive decline, most of the people that have the psychosis symptoms are already cognitively impaired, and it goes along with that. The hallucinations are things we see that aren't there. Initially, people have insight. You can say, there's no dog over there. They don't allow dogs in this building. Oh, okay. It's gone. It'll go away. But as the years go by of having hallucinations, people lose their insight, and it's harder and harder to tell their brain it's not there because their brain is telling them, it is there. I see it. There can even be times where people can see and feel something or hear it. And so that's a situation where it's just it's from the progression of the psychosis. Hallucinations are things we see, but there's also false beliefs. Those are delusions. Delusions can be paranoia-like, and even just typical Parkinson's can have anxiety with it, but it's usually not to the paranoia stage until somebody goes into the cognitive impairment area and it progresses to where that's part of it. It can be, most often it's related to love or money. So somebody's trying to steal from me. You're not my spouse, you're an imposter. Where's my spouse? When it is your spouse. The care person bringing me meds, they're trying to kill me. They've got poison in the pills. I don't want to take the pills. Things like that. The SWAT team has actually been called out here in Green Valley a couple times from middle of the night. Somebody waking and thinking that there's an armed intruder in the house. And it's the Parkinson person that has that delusion or hallucination, whichever it is. And so we've seen from the news that that's not a very good thing to have happen. Things can go wrong. And so those are important things to deal with the provider. Okay. Yeah.
What about cervical dystonia and Parkinson's together?
The question is, what about cervical dystonia and Parkinson's together? Cervical dystonia is, it's a muscle that's spasming, but it's different from the rigidity of Parkinson's because the rigidity of Parkinson's is all the muscles, the flexors and the extenders are equally tight. Everything's tight. And so if you were to bend a lead pipe, no matter which way you go, it's tight. That's what they talk about limbs, feeling like a lead pipe. A dystonia is a certain muscle of the body or muscles of the body that is spasming and tight. And it can either cause movement of that limb or area. For instance, dystonias in the neck can sometimes cause a head tremor, but it's just the spasming of the muscle. Or it can cause a fixed posture, like if people have a foot that turns in and they can't get it straight. So dystonias can happen in Parkinson's as a part of the Parkinson's. It can also occur in Parkinson's related to the medication dose. If you're too low, sometimes you get more dystonias. If you're too high, sometimes you get more dystonias. However, if you're on the uptake of your medicine or on the downtake, sometimes you get dystonias. So it can happen anytime. Cervical dystonia is a pretty common, one of the common adult onset dystonias anyway. So it may or may not be related to that person's Parkinson's. It can cause the head to pull one way. The muscles tend to be asymmetrical there. And the biggest thing is if it causes pain, then a good treatment is Botox. Botox injections into the muscles. The good thing is that if they do a perfect injection, you're good for a while. The bad thing is if they give you a bad injection, it wears off. So if a bad injection wears off, a good injection wears off, meaning the Botox is just a temporizing measure. So it's hard to know if it does or doesn't have a relationship. Yes? Oh, the current research in psychedelics and things like the mushrooms and everything? I don't know a lot about it, so I can't tell you a lot about it. Yeah, he says there's a lot of successful things coming out of Oregon and Washington about the different studies in psychedelics being used for treatment of different things. So, yeah. Other things. We good? Oh, one right there. Sorry.
Would you say in general, when people start having behavioral issues, the anger, the aggression, acting out, is it always related to the beginning of cognitive decline?
No. There can be other times where if somebody is just not adjusting well, like I saw somebody today that she's got mild cognitive changes, but nothing drastic. And it's just some people deal better with changes in life than other people, and sometimes people just lash out and get angry. But with any of the mood changes, it's totally possible that the Parkinson's is affecting that part of the brain and contributing.
So you would
But-
address it as a mood problem and treat it as a mood problem?
Well, if not a mood problem, at least doing some kind of cognitive behavioral therapy, some kind of psychological talk therapy or something to help out. Because if it's something like anger, it's like, would that really be benefited by any of the antidepressants? I don't know. The psychologist would be better to tell you that. But getting them to the psychiatrist is the one that can do the medications and say yes or not, they help. And generally the psychologists aren't able to prescribe medications, but they also do the talk therapy. So there's somebody in the second row first.
So going back to the question about cervical dystonia and Parkinson's, if somebody is diagnosed with just dystonia and told you absolutely don't have any of the symptoms of Parkinson's other than the dystonia, what are the chances that they will then end up with Parkinson's?
Good question. I'm not aware of a link between a focal dystonia, one location, and the development of Parkinson's. So it's, at the least, it's the same as the rest of the population. You're still aging, still able to develop Parkinson's. But there are things that a person like that could perhaps get insurance to cover to look sooner than when physical symptoms start. Because looking at you and looking at anybody and saying, I don't see tremor, I don't see this, I don't see that. hopefully the person is very experienced in looking for those things when they make that comment. But even so, there's a high rate of being wrong at the initial time of diagnosis, especially for regular doctors, but even for movement disorder doctors. That's why it's like following it over time and making sure that it still tracks with what you think it is the best thing. But for somebody that's got the dystonia, they're thinking, there are, you could check for genetic tests. If the insurance would cover it, you could get a DAT scan. Perhaps the muscle biopsy would be cheaper than the DAT scan. I don't know what it costs for that, but those would be different ways to look at it from a different angle other than, well, this is somebody's opinion. Make sense? Okay, in front row.
As a mental health therapist, I can address
Okay.
the fact that depression can present as anger
Okay.
anytime.
Okay.
And then I wanted to ask about...
Let me repeat that. So for those of you who didn't hear, a health provider says that depression can come across, like anger can be a symptom of depression. So just because it's anger doesn't mean that depression isn't causing it, right? Okay, good enough. Okay, so what else?
And then marijuana and Parkinson's.
Okay, so the other thing is, what about marijuana and Parkinson's? So far, there's not any good studies yet to say what to expect from it. I have followed patients that have tried it, and each time I hear, oh, you tried it? What form? What do you think it helped with? What didn't it help with? Trying to keep my little black book, what do I see? It's been across the board. Some people like it, some people don't. Some people feel it helps, some people don't. And the symptoms that it helped with were different for everybody. There was something I saw recently, though, about older people using marijuana. It wasn't Parkinson people, just older people. And I don't remember what it was, but it was suggesting that there were negative health side effects. It was a news article maybe a month or two ago, but I don't remember what it said. So it's always just keep your eyes and ears open about anything new for it. So.
All right, let's get Dr. Thank you all very much for being here today. And we try to have Dr. Reed back, every couple of years at least.
Yeah.
Char, did you have anything to add?
I think the next SAT class is the 16th, I think it is, and it's going to be on oral hygiene and aspiration pneumonia. They'll kind of go together. So watch my emails, you'll hear about it.
Yes, tomorrow we are going to kick off Parkinson's Awareness Month. For those of you that like to walk or want to get into the pole walking,
I do want the slides.
Okay.
and we're going to do a couple of
I can give it to you just by jump drive and just stuff. I can, or I can